I'm delighted to see the results of the reviews of the best clinical research grants around the country. It's a demonstration of the outstanding quality of clinical scientists working in some of the best institutions in the United States. The Clinical Research Forum, which works on clinical research, advocates for it, tries to work with both providers and also researchers and government and pharma to generate that research, has developed this very fine mechanism of identifying the 10 best clinical research papers and programs over the last year. It's sensational as to how wide the application is. It's stroke, it's cancer, it's heart disease, it's every conceivable disease. We want to see greater recognition of the wonderful clinical researchers who do this. We want to see adequate support from everywhere, NIH, pharma, foundations, philanthropy for this research. What it's proving is that clinical research is one of the best answers to finding cures, treatments, ways of helping in diseases which affect so much of our population.
This work really represents a totally new paradigm in how we treat cancer. We're not using chemotherapy or drugs that are very nonspecific, but instead we're using the specificity of the body's own immune system to target incurable tumors, lung cancer, melanoma, renal cancer, and many others. So basically, if you have a tumor, you want the immune system to kill that tumor. But unfortunately, tumors make a protein known as PD-L1, and that keeps the immune system away. So what MPDL3280 does is it's an antibody against that PD-L1. It neutralizes it, so the immune system can then kill the tumor. Well, this work was important because our team actually obtained biopsies from patients before, during, and after treatment. And by doing that, we understand exactly who's more likely to benefit than others, and what the mechanisms are that result in that benefit. That's hugely important because it can allow us to predict in advance who's going to benefit so that we can treat more people. And for those who are not going to benefit, we can find other combinations and ways to treat them more effectively in the future.
Tissue plasminogen activator, or TPA, is a clot-dissolving medication. When given within 60 minutes of arriving at the hospital, it can help dissolve the clot, restore blood flow to the brain, and leave patients with less disability.
Every minute that a blood vessel to the brain is blocked, there can be as many as 2 million brain cells that are dying.
This time frame is known as door-to-needle time. However, less than a third of stroke patients in the U.S. were getting TPA within the 60-minute time window.
The Target Stroke Initiative was designed to improve the timeliness of evaluating patients with stroke.
Dr. Greg Fonarow from the University of California, Los Angeles, and co-authors evaluated outcomes at more than 1,000 U.S. hospitals before and after the initiative was rolled out.
Just prior to the initiative, only 29% of patients had door-to-needle times within 60 minutes. After the initiative was put into place, this had increased to 53.3%.
The study appears in JAMA, Journal of the American Medical Association.
There was a reduction in mortality. More patients were able to be discharged home. More patients were able to walk on their own. And importantly, a potential complication that can develop bleeding into the brain, that was also reduced.
Gene therapy first started approximately 25 years ago, and the first disease that was successfully shown to be cured with gene therapy is a disease commonly known as the bubble boy disease, severe combined immunodeficiency, and particularly the X-linked form or SCID-X1. The first trials for SCID-X1 cured the SCID. However, 5 out of the 20 boys treated for this disease developed leukemia caused by the gene therapy. This was a major setback in the field, so we sought to address this problem by finding a way to keep the gene therapy as effective as it was, but make it safer. We treated 9 boys on this study using the modified gene therapy vector, and not only did we find that 7 out of the 9 boys were cured of their SCID, we also found that there is no longer targeting or turning on of genes that could cause leukemia. This is preliminary evidence, but we hope that this means that gene therapy can be extended to a wider variety of diseases and conditions in the future, both safely and effectively.
The overview of the project was to look at 12 different cancer types and ask whether by using multiple genomic technologies at once that we would reclassify cancers in a different way. And in fact we did.
And what we found is that the 12 different tumor types collapsed into 11 main groups, where we see instances of both divergence, or tumor types that separated into multiple groups, or convergence, where tumors from multiple different tissue sites collected into a single group.
So there was about a 10 to 15% sort of switching around of the biologic subtypes of breast cancer based upon the old classification from where the tumors arose to the new classification based on the genomics. So I think this is an important step forward for personalized medicine, because now for those 10 to 15% of patients, the biology is probably saying something different than we thought previously.
My name is Alana. When I was 12 years old, I was diagnosed with fibrolamellar hepatocellular carcinoma and had 2/3 of my liver resected.
It's a serious malignancy that predominantly occurs in adolescents and usually in females. It's not curable unless it's surgically resected, and that's really the only therapy we have right now.
When we first started, we didn't know that much about fibrolamellar. We didn't know if it was one disease related to hepatocellular carcinoma. We didn't know if there was a single mutation that would cause the disease, or if it was something that was environmentally triggered.
So we took two approaches. We searched through all of the DNA and looked for alterations in the sequences, and we also looked for alterations in the amount of each gene that's made.
Fibrolamellar is a very rare tumor. It's presented certain challenges when we started our research. First, we had to find samples to work with. In order to do that, we reached out through multiple social networks, as well as through Memorial Sloan Kettering, who had a tissue bank and luckily had samples available that we could use.
One of the first things we found is that the DNA, both in the tumor and the adjacent normal tissue, was completely clean of mutations. This is very different from what's observed in most adult cancers, which have been around for a long time, allowing for many mutations to accumulate.
We did find that many of these genes were altered in their levels. Some increased, some decreased. Some of these genes are called oncogenes, so they're known to drive cancers. Some of these made a particular kind of protein that modifies other proteins, so that's called a kinase. And since these kinases affect many different things, and they're often found in cancer, we looked at these. While looking to see if the cell was using the normal form of these enzymes, we found something strange in every single patient. One of the kinases had an altered form, so its first segment seemed to come from another gene. So it was called a chimera, which comes from the Greek form of the word. With this information, we've been developing diagnostic tests for fibrolamellar, and we also have specific targets to hit now. So we can both hit the fusion protein, which fortunately doesn't exist anywhere else in the body, and we can hit the things turned on by the fusion protein. And we now also have mouse models of the disease where we can test these drugs.
We're dealing with HIV infection here, chronic infection that unfortunately is not cured with current medications. And our approach now is to use genetic editing.
The study that we did is to take cells from patients infected with HIV that have this protein and try to genetically engineer them to remove this protein to make a population of cells that are resistant to the HIV infection.
So we were able to monitor what happened to the HIV infection in the patients, as well as their CD4 counts, which is their immune system, following the infusion of the modified cells. And we found a very gratifying increase in the level of CD4 cells in the patient. It nearly tripled. And these levels have been remained sustained at an elevated level for at least a year after infusion. So that's an encouraging signal that we may be accomplishing in what we wish to do, which is to make their immune system resistant to HIV infection.
Every year, more than 750,000 patients experience either severe sepsis or septic shock. Our goal in this NIH-funded multi-center trial was to determine if there is a singular best way to treat these patients. We tested an invasive central venous catheter-driven approach and two less invasive approaches, protocol-based standard therapy and usual care, in 1,341 patients enrolled across 31 hospitals over the country. Interestingly, we found no difference in mortality across the three approaches, with a hospital mortality rate that was far lower than only a decade ago. Our data confirm a simple axiom. What truly matters is early septic shock recognition and treatment with antibiotics fluids, and selected other agents. And it is not so much the specific approach to resuscitation. Of note, a concurrent Australasian trial found similar results. Therefore, viewed more broadly, our study is consistent with the guiding principle of the original 2001 Rivers trial, which first brought early sepsis care to prominence. Look early and treat early.
Cranial nerve stimulation of the upper airway via the hypoglossal nerve has substantially improved patients' daytime sleepiness and also substantially mitigated risk for long-term cardiovascular outcomes. This work is really part of a team effort, and at the University of Pittsburgh, the surgeon who did the implants was Dr. Ryan Seuss, who is the second author in our paper along with myself. Dr. Kingman-Stroll was the third member of our writing team and critical to the production of this publication. We recently published the results of the STAR trial in the New England Journal in January of 2014. The study involved 126 patients, which we followed for a year, and demonstrated substantial reductions in the apnea-hypopnea index, the oxygen desaturation index, and patient-reported outcomes that addressed daytime sleepiness and quality of life. This work demonstrates really how research can translate into better patient care and is a good example of translational medicine.
Clinical depression is diagnosed in 10 to 15% of pregnant women in the United States, and increasingly these women are being prescribed antidepressant medications. In 2005, the FDA issued a warning indicating that exposure to commonly prescribed antidepressants may increase the risk of malformations of the heart in the developing fetus. We tested this hypothesis in a large observational study, including close to 1 million publicly insured women across the United States. After controlling for the role of depression, its associated conditions and behaviors, and other potential risk factors, we found no substantial increase in the risk of heart malformations attributable to antidepressants, suggesting this should not be an important consideration in the treatment decision. This study addresses an important piece of the complex puzzle about the safety of antidepressants, that is teratogenicity. Additional research will be needed to evaluate the entire spectrum of risks and benefits associated with these medications during pregnancy.
Management of children with vesicoureteral reflux has been controversial. Urine flows backwards from the bladder towards the kidney, making them more likely to have recurrent urinary tract infections and possibly kidney damage. Through NIDDK funding, we conducted a definitive study to settle this question. In a placebo-controlled study, we randomized 607 children diagnosed with reflux following a urinary tract infection. Antimicrobial prophylaxis reduced in half the proportion of children with UTI recurrences. Twice as many children in the placebo group had treatment failure. We found no differences in kidney scarring at 2 years. Children who had fever with the index urinary tract infection or who had bladder and bowel dysfunction derived the most benefit, with 60 and 80% reductions in UTI recurrences respectively. In summary, in children with vesicoureteral reflux diagnosed following a urinary tract infection, antimicrobial prophylaxis substantially reduced risk of recurrence, but not of renal scarring. Our findings have broad public health implications for the children affected, their parents, and the pediatric providers who care for them.
It's delightful for all of us to see the outstanding talent in clinical research and the wonderful work that's been done this year. The Clinical Research Forum strives to ensure that clinical research is supported, that it continues to contribute to the health of the public and the reduction of disease. I'm very proud to be associated with this marvelous effort and want to congratulate all the recipients of the awards this year.